Okay, thank you, Mr. Chairman. So I will cover about the fascia iliaca blocks. Okay, this is my outline of my presentation. First, okay, we'll talk about introduction, a little bit of anatomy, advantages, and the technique. Okay, for the introduction, fascia iliaca was described in 1989. It's a famous anesthetic technique for surgical procedure involving hip joint and femur, right? So formerly known as 3-in-1 block. Why? Because it covers 3 nerves: femoral nerve, obturator nerve, and lateral femoral cutaneous nerve. Okay, for the anatomy, 4 major nerve supply of the lower limb: sciatic, femoral, obturator, and lateral femoral. So majority of them arrive from the lumbar plexus, except for the sciatic nerve already, also from the sacral plexus. Okay, from this diagram, you can see where is the fascia iliaca. Okay, this is the fascia iliaca. All right, so it's near cover the femoral nerve. All right, and then the lateral femoral cutaneous nerve here. So where the location that you want to give block, either you can do here or here. It doesn't matter, because if you do in the middle, you need volume. So when we talk about compartment block, you need more volume, right? So how much volume you need to give for fascia iliaca? At least 30 to 40 mils, right? The most important thing, fascia iliaca also is not meant for anesthesia. It's just meant for analgesia, all right? So you need, if you have a patient want to give a AKA, you cannot use fascia iliaca, all right? But you can supplement given GA and supplement with fascia iliaca for the post-op pain management. All right, what are the coverage? Since discover 3 nerves, so as the dermatome is almost cover all the anterior compartment of the thigh and the knee, all right? For the osteotome, cover 90% of the femur and patella, all right? So what are the advantages of given fascia iliaca block? It's a good flow of the hip and knee, significant reduction in the morphine requirement, can reduce rate of DVT, can promote early mobilization of the patient, and also is quite easy to perform, right? So what are the indications? So for the anesthetics, we think that is for the elderly patient with coexisting respiratory disease, maybe a patient came for total hip replacement, you want to use spinal, and to avoid GA, you supplement with fascia iliaca block, right? Fascia iliaca also can be given as a single shot, or you can give continuous infusion, all right? So perioperative analgesia for patient with neck or femur fracture, adjuvant anesthesia for the hip surgery, anesthesia for the above knee operation, and anesthesia for the knee surgery. However, you must remember knee surgery, you have anterior and posterior aspect. So fascia iliaca only cover the anterior aspect of the knee. ACL, yes, you can cover with fascia iliaca, but if your patient did some PCL, cannot, you have to cover with sciatic, right? So we also have a clinic, ED. Now ED start doing the regional block. So in ED, what fascia iliaca can be used? Maybe for the neck or femur fracture, patient came freshly with severe pain, we can with fascia iliaca. For the hip dislocation, right? For the femur fracture, patellar fracture, acute ACL tear, or laceration wound at the thigh, or degloving injury at the thigh, right? So it says fascia iliaca is a current gold standard in the management of neck or femur fracture with pain unresponsive to intravenous opioid and paracetamol, according to the NICE guideline, right? Okay. We also say early administration of fascia iliaca recommended in patient with fractured neck or femur. Again, fractured neck or femur. Okay. This one is from the Scottish guideline. And then, who can give the fascia iliaca. Not only anesthetist, ED also can give fascia iliaca. So this guideline from the in 2020, fascia iliaca block should be available in emergency department as part of the pain management strategy for patient with fractured neck or femur. So now, not only NS who give fascia iliaca, our colleague in the ED department also start giving fascia iliaca, right? There are two techniques, okay? You have infrainguinal or suprainguinal. For this, I only going to talk about suprainguinal. Okay. So patient in supine position, right? So what you aim to, this is area ASIS, okay? You put one finger breath away from ASIS, use your linear transducer, okay, to shine. What is your aim to see is this one, right? You will see sartorius muscle, then internal oblique muscle, and then this is fascia iliaca. So your aim is to deploy your local anesthetic around here in the suprainguinal approach. As you can see here, the muscle is just like a bow tie. So some people mention it as a bow tie appearances, right? So we'll deploy your local anesthetic is around here. So when the LA was given here, we push away the iliacus down. Again, you need 30 to 40 mils, right? Because you need to cover 3 nerves. Okay, this one is, you can see the ASIS. This is the internal oblique. So the needle came from here below the internal oblique. Okay, go through below the internal oblique. And local will be deployed. You can see, you see separation, right, by the local anesthetic. So what to give? Normally for fascia iliaca, it depends on patient weight. Normally, if you use half of the concentration, let's say you use naropin, you can use 0.375% of naropin, 30 mils, or you use bupivacaine, 0.2%. Can you use 0.5%? Can, but depend on your patient weight, because you need large amount, right? This video also almost the same, all right? Okay, you have the muscle, and then you can see there's an artery there, right? Deep circumflex iliac artery. So sometimes, most of the time, the fascia iliaca is below the artery. So if you cannot see the artery, it's okay. Not all patients you can see the artery. Just go below the internal oblique muscle, right? Okay, this, the needle came and we deploy. Okay, so we deploy the LA, about 30 mils of LA. Okay, that's all for my presentation. Thank you.